So I'm going to talk about the mechanisms and consequences of poor CD4 recovery during antiretroviral therapy. First, to set the stage, we know that the life expectancy gap in people living with HIV is narrowing compared to the general population, particularly in those who have higher CD4 nadir T cell counts. Right now, there's about a 9-year gap in life expectancy, and that gap narrows to just 6 years in people who started ART at a high CD4 count. But the comorbidity-free years continues to be lower in people with HIV. There's a gap of about 15 years here. And even in people who started at a high CD4 count above 500, they still have about a 10-year gap in comorbidity-free years. So morbidity, multimorbidity remains an important problem, including many of the morbidities listed here. What's more, life expectancy is further reduced by low nadir CD4 counts. And so these are data from the NA Accord study in North America several years ago, showing that individuals with a CD4 count below 350 at the time of ART initiation actually have a much lower life expectancy than individuals who start at a CD4 count above 350. It's about 20 years lower, so pretty dramatic effect. And that's important because of the 20 million or so people around the world who are on ART right now, the vast majority of them started at a CD4 count below 350. So this gap in life expectancy is going to be something that we're going to be dealing with for a long time to come. And what's more, mortality is even higher in those who have poor CD4 recovery during ART. So this is the largest study ever conducted addressing this question in the ART-CC and COHERE collaborations. This is a multi-continent, a multi-cohort study of people who started ART at a low CD4 count and achieved and maintained viral suppression for at least 3 years. And what they did is assess whether the CD4 count at 3 years of suppressive ART predicted the subsequent mortality rates. What they found is that people who started at a CD4 count below 200, which was about 15% of their people who continued to have a CD4 count below 200 despite ART, which was 15% of this cohort, had a mortality rate of 2.5% per year. So put in perspective, over 10 years, that's a mortality rate of 25%. 1 in 4 people who fail to restore normal CD4 counts and plateauing at a low CD4 count below 200 die after 1 decade. And what's important is that this is not just AIDS-related diagnoses and infections. 63% of the causes of death here are non-AIDS related causes of death, cardiovascular disease, cancer, among many other morbidities. In fact, it's the same distribution of causes of death among people who died at higher CD4 counts. And so that's an important point to keep in mind. This is a high-risk population at risk for multimorbidity and mortality. And here's a list of many of the morbidities that are increased in people with treated HIV, particularly those who have a low CD4 count despite longstanding viral suppression. Now, there's been much focus on the contribution of persistent inflammation to multimorbidity and mortality during treated HIV infection. And this is a pivotal slide from the Insight Network, which shows that higher levels of the inflammatory marker IL-6 and the coagulation marker D-dimer on the right predict an increased risk of non-AIDS events or death over the next decade. And so these are really strong effects. And the important point is that a CD4 count also predicts these morbidities, and they're independent of each other. So after adjustment for CD4 count, the inflammation remains associated with events. And the same thing is true of CD4 count. After adjusting for inflammation, there remains an effect of having a low CD4 count. And this is also seen in a study that our own group did many years ago in the SOCA cohort. The SOCA cohort, or the study of the ocular complications of AIDS, was notable because it was an extremely advanced cohort of patients with HIV. The median nadir CD4 count of only 30. So half of the people had a CD4 count below that at ART initiation. And here, the relationship between inflammation and mortality was even stronger than we've seen in other studies. Excuse me. With an odds ratio of 70 for IL-6, comparing the fourth to first quartile. So this is a really extraordinarily strong association. And as in the Insight Group's studies and in other studies in the ACTG, a low CD4 count continues to predict events independently of inflammation in these studies. So both low CD4 count and inflammation predict disease. But it's also true that it's the people who have poor CD4 recovery that have the highest levels of inflammation. And so Michael Lederman's group many years ago showed this is the case. The immunologic failures, he called them, people who have persistently low CD4 counts below 350 in red, had higher levels of inflammation, IL-6, coagulation, D-dimer, and also soluble CD14, a monocyte macrophage activation marker associated with microbial translocation, also tended to be highest among people who have poor CD4 recovery compared to those who had higher levels of CD4 recovery. And it's also true that most drivers of inflammation are also more active in people with poor CD4 recovery. So our own group had looked at microbial translocation directly in gut biopsies of people living with HIV. This brown stain is a myeloperoxidase stain for neutrophil infiltration, responding to breaches in the gut barrier. And you see that there's a whole lot more neutrophil infiltration in people with poor CD4 recovery on ART than in people with optimal CD4 recovery. And both groups have much more than in HIV negatives. And there have been multiple efforts to try and reverse microbial translocation during ART, but so far they've all been unsuccessful to date. Trials of rifaximin, sevelamer, probiotics, and mesalamine, all negative. So we haven't been able to reverse this process just yet. And why is this occurring? Well, why does it persist during ART? Well, one of the reasons may be due to continued HIV expression from cells in the latent reservoir in the gut. The gut is home to the majority of infected cells during suppressive ART. In a recent study by Jake Estes, and in our own study here with Bonnie Howell and colleagues from Merck, we found that rectal P24 levels, so protein expression by HIV, while highest obviously in people who are untreated with a high viral load, was significantly higher than we see in HIV negatives. In both immune responders, people with CD4 count over 500, but particularly high in people with CD4 counts less than 350. In fact, despite a small sample size, we readily appreciated higher levels of HIV production compared to those that had greater CD4 recovery. So there's a real link here between the burden of HIV being expressed in tissues and the extent of CD4 recovery. The extent of HIV expression in tissues is also directly linked to markers of microbial translocation like soluble CD14, as we showed in the same study. We've also seen that other root drivers of the inflammatory state, like asymptomatic CMV co-infection, might also be a greater problem in people with poor CD4 recovery. My own group did a trial of valganciclovir in individuals with poor CD4 recovery about a decade ago. And while the original trial reported that we significantly reduced T cell activation markers in this setting, more recent data from our lab has shown that multiple other pathways of immune activation that more strongly predict morbidity and mortality in this setting were also decreased by this approach, soluble TNF receptor 2 and soluble CD163 here. Now, all this has inspired a trial of the CMV terminase inhibitor, letermovir, that will start soon in the ACTG, and it will determine if treating asymptomatic CMV reduces inflammation and cardiometabolic risk in treated HIV. And importantly, half of the people in that trial will have CD4 counts less than 350 because we expect that the intervention is likely to work even better in people with poor CD4 recovery. So what mechanisms might contribute to poor CD4 recovery? Well, one important mechanism is lymphoid fibrosis. And Tim Schacker's group and Ashley Haas many years ago suggested that lymphoid fibrosis in the follicular reticular cell network, that's the FRC network for short, in the lymph nodes exists at the very earliest stages of HIV. It gets worse with progressive HIV infection, and it fails to reverse despite suppressive antiretroviral therapy. You can see this fibrosis as the blue collagen stain here. This is a trichrome stain for collagen. Lots of that collagen in the lymph node of someone with HIV and hardly any of it in someone without HIV. So why is that a problem? Well, this FRC network is where a major growth factor for naive and central memory T cells, IL-7, is produced, and where these cells encounter the IL-7, supporting their survival. And so when you have lots of scarring in the lymph node in this site, these naive T cells, which are responsible for maintaining CD4 homeostasis, fail. They die more often. They have impaired survival, and that lowers the total CD4 count in the blood. In fact, Tim Schacker's group has related the extent of fibrosis in the lymph nodes with poor CD4 recovery on ART, and in some cases even declining CD4 counts despite ART. Now, there have been many efforts to try and reverse lymphoid fibrosis directly. ACE inhibitors and angiotensin receptor blockers have been thought to have both anti-inflammatory and anti-fibrotic effects. But randomized placebo-controlled trials of these agents have failed to demonstrate any benefit on lymphoid fibrosis in the context of treated HIV. There are other mechanisms. Anti-CD4 antibodies are also induced in most people with untreated HIV. These autoantibodies directed against CD4 decline with ART, but persist at higher levels in those with poor CD4 recovery. So this is a study from Wei Zhang's a group at the University of South Carolina. And what she shows is that immunologic non-responders, people with CD4 counts less than 350, have higher levels of these antibodies than immunologic responders, people with CD4 counts above 500. And once these anti-CD4 antibodies bind to an uninfected CD4 T cell, they make those T cells susceptible to a natural killer cell mediated killing via ADCC. So this is a way by which even HIV uninfected CD4 T cells can die in immunologic non-responders. And there are other mechanisms of bystander CD4 killing that will be discussed in the next talk by Walter. So I don't want to steal his thunder, but look forward to that. So to conclude, people with HIV with poor CD4 recovery are at very high risk for morbidity and mortality. They have the highest levels of immune activation, the greatest burden of HIV in tissues, greatest microbial translocation, and probably other drivers of inflammation like asymptomatic CMV replication as well. These are the folks that are most in need of novel interventions. Now, what about the mechanisms to explain this poor CD4 recovery? We think lymphoid fibrosis is playing an important role. It impairs naive CD4 T cell survival. Autoantibodies may also play a role against CD4, among other bystander mechanisms that you'll hear about in a little bit. But one important point to make here is that all of these mechanisms are linked to HIV persistence in tissues. And so interventions that might reduce HIV expression from cells might be highly worthwhile targets worth investigating. So with that, I'll stop and acknowledge all the people who helped contribute to some of the work that I shared with you today and my funding sources. Thank you.